me take roll now. Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present.
Director Epen?
Present.
Director Wallace?
Very good. We'll move on to the communications section of the agenda, oral communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Seeing none, we'll move on to written communications. Are there any written communications, Cheryl?
Yes, and the written communication was provided to the board.
Thank you. Thank you. Very good. Okay, we'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed removed agenda item later in the board meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Seeing none. Does any member of the public want to remove an agenda item from the consent calendar? Seeing none. May I have a motion to approve the consent calendar items A and D? A through D.
I move that the Board of Directors approve the consent calendar's items A and D.
It should be A through D.
A through D.
Yeah. Second that.
Good. Thank you, Cheryl. If we could call roll.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Wallace?
The calendar is approved. We'll now move on to our presentations. Kimberly, if you could introduce.
All right, we have two presentations this evening. The first is a presentation we are providing and presenting to you for approval is the fiscal year 26 consolidated budget for the healthcare district. And I will, Ajay Sial and Jessica Haviland will be presenting the budget this evening to you for approval, and I will give their bios. But just before we start, I do just want to say one thing about the budget. I think one of the things I continue to say, the only thing that is certain is the uncertainty within which we are living right now. So you will, and I think we all can't open the newspaper or read read online about the different factors that are impacting us at both the federal and the state level. And at the federal level, in terms of the budget reconciliation that is going on and the potential cuts to Medicaid, ultimately Medi-Cal here in this community, and also other things that could impact us in terms of things like tariffs also that could impact our ability to purchase supplies and pharmaceuticals and those types of things. On the state level, I think we also know there is a budget deficit of about $12 billion that is also trying to be reconciled, and the governor and others are working on that, but also potentially there are impacts that could happen to residents in this community who have certain types of insurance like Medi-Cal. So there's a lot of uncertainty that we are living within, and we may have to bring back a budget amendment if there are certain factors that do play out and we understand what those impacts are. I think we also understand that there's a lot of work we need to continue to do as a health system in terms of looking at our efficiency, continuing to integrate as a health system, and also continuing to look at revenue growth. So those are also very important to us as we look to currently and also to the future, and continuing to be able to serve our community as an independent health system. So I'd like to start by just introducing our two presenters. As I said, it's my pleasure to introduce Ajay Sial. He's our interim senior vice president and CFO, and he joined Washington Health just in December of 2024, and is responsible for financial and capital management, FP&A, revenue cycle, treasury, and supply chain functions. He has a long and impressive history of managing the finances of multiple systems and hospitals and leading the financial transformation of complex organizations through prudent management and strategic activities, including financial management, business development, facilities management, IT management, and fundraising. Prior to joining Washington Health, Ajay served as the interim CFO at University of Missouri Health, CFO at University of California, Irvine Health, Loyola Medicine, and University of Kentucky Health. He is also founder and board member in the biotech industry and has worked with a number of biotechs, primarily in the neuroscience space. Our second presenter this evening is Jessica Haviland, and she is online, Senior Director of FP&A and Treasury. She joined Washington Hospital Healthcare System in March of 2024 after working the last 10 years at Providence St. Joseph Health System in Washington. At Providence, Jessica was a finance director leading the $6 billion capital portfolio. Prior to joining Providence, Jessica was at Walmart stores in Bentonville, Arkansas for 10 years in various finance functions focusing on the U.S. division. Jessica graduated from Oklahoma State University with a Bachelor of Science in Business Administration and continued to get her Master's in Business Administration as well. So I will turn it over to Ajay to begin.
Great. Thank you for that. I appreciate it. And thank you for the comments earlier. I think it's a really good segue into what we will be proposing as a budget. Somebody actually wrote a really nice letter, so I'm going to use that as the basis for some of my initial remarks, and then we'll get into the details of the budget. As you saw, the 26 budget outlines net operating revenue of $685.2 million against total operating expenses of $689.9 million. This leaves us a projected net operating loss of $4.7 million, and after we add back in our other outside revenue, the net income of $16 million. And we'll go through all the details in a little bit. Capital investments are budgeted at $100 million, funded through $60.1 million in bond proceeds and philanthropy, and an additional $40-ish million supported by internal cash flow. Additionally, there's a projected net loss, and we'll show you this, of $32.4 million to support the operations of the Washington Hospital Development Corporation and the Washington Health Medical Group, who are our key affiliates in advancing our mission, improving community health. Looking back at 25, I think this was a transformative year and a very pivotal year in the history of Washington Health. In July 1st, we officially launched our Level 2 Trauma Center and closed a huge gap in services in southern Alameda County. This was a big achievement, cross-system collaboration, commitment from our entire team, nursing operations, and by the year end, we'll have treated over 1,865 trauma patients and really helped our community and through, in addition to that, through education and other endeavors that are part of this program. We also launched a new mission, vision, and values and rebranded as Washington Health with a new logo to really reflect our evolution into an integrated health system. And I think, and these are great big steps for our system as we look into the future and the investments that we are making, as I pointed out earlier, in our affiliates. We've also continued to make significant infrastructure progress to support the community needs for now and the future. One of them, some examples of that are construction of the UCSF Washington Cancer Center, which should be completed by the end of calendar year 25. The next phase of the infill project for the Morris Hyman Pavilion, new operating rooms, imaging center, pharmacy, and other support areas, which will continue through FY26 and possibly open in like early 27.
Yeah, I think construction should be done around August or so, and then by the time we get approval through the state and all those types of things, so probably
Yeah, towards the fourth
the end
quarter.
of 2016,
Yeah.
27.
Extensive work also occurred with the architects on the design of the expansion building, which will house the birthing center, intensive care unit for infants, med-surg units, and other departments that need to be moved from the main hospital tower in order to meet the state's mandated seismic requirements. Some of our operational improvement performances that were generated in FY25. We achieved a 2.1% increase in gross revenue compared to the budget. We've expanded our cardiac service line with advanced procedures, including TAVR, Watchman, MitraClip. Our length of stay has come down from 5.4 to 5.2. We're going through and we're assessing how our revenue cycle is performing, and I think that will pay off dividends in the future, as well as enhancing our 340B program and really working on trying to see how we can provide those benefits to our community members. We also negotiated a bunch of payer contracts during the year, such as Alameda Alliance, Kaiser Trauma Contract, United Healthcare HealthNet, Blue Sheet CalPERS contract. And this work will continue into FY26. And these contracts, when we negotiate them, are usually 3 years and have escalators built into them for every year. So that's the way that we do that. And during 26, we'll be focused on the Blue Shield, Aetna, and potentially the Blue Cross contract. So there's a lot more work to be done here on improving our managed care contract. However, as we've continued to improve on our top line, and our expenses have been increasing too. Rising pension and OPEB costs and medical plan benefit expenses have driven to a large extent a projected FY25 net operating loss of $6.1 million. Majority of that is coming out of our benefits area. And we'll continue to focus on workforce-related costs, staffing, premium pay, and productivity improvements as we go into 26. Kimberly mentioned the external environment, and I think that remains challenging, and I won't get into the details. I think she very nicely went through those. In terms of our capital investments, we will present a capital budget of about $100 million. Majority of that, about $60 million, will be funded through our bonds. The remaining, roughly about $39.1 million, through our internal cash flow. And we will consider delaying or phasing non-critical capital projects if we see if the environment is not conducive to that. And as Kimberly mentioned, flexibility will be key to ensuring we maintain our financial health, including our days cash on hand as we go through the year. So thank you for indulging me on sort of laying out where we are. Now we'll get into the specifics of our budget presentation. And if you can move to that first slide. I think we talked about the challenges enough. I won't go through them another time. I think Kimberly nicely talked about it. I will talk about this analysis here. This is, as you know, a SWOT analysis on how we are looking at this budget for this current year. We talked about the contracts and things like that in our payer negotiations. We continue to work on that, and I think the work that we've done this in FY '25 will continue to help us in FY '26. Our patient volumes, you'll see, are increasing, and all of the, between those two, there's decent revenue gains. Our labor is relatively stable. We've negotiated long-term union contracts, and they're in the midst of those years. Our payer mix has been trending more towards government payers, and we'll continue to probably see that shift. And as Kimberly mentioned, as we go through the budget, we've adopted a conservative approach due to the uncertainties that we continue to expect here. On the weaknesses, we talked a little bit about the rising pension and OPEB obligations, which result in increased employee benefit costs, which contribute to our expense line item growth. Our cash flow constraints, driven by significant capital investments, the ERP facilities, we continue to do that, and as I mentioned earlier, we'll continue to watch that closely. Operational strain due to multiple competing priorities. So we have the ERP we're working on. We have lots of capital projects, and while we're also negotiating with all the other uncertainties and trying to improve productivity and all of those good things. And those uncertainty at the state and federal level. Some of our opportunities, I mentioned our revenue cycle improvements and our and the consultant we've brought in who's helping us get ready for the new year. And we certainly improve to see we hope to see an improved case mix as well as reduced denial rates. We've gone through an excellent exercise around the strategic plan and have come up with a strategic map. And there are both revenue generating as well as cost savings opportunities there, which we hope to implement during the year. And we also look to enhance our operational efficiencies, length of stay, the odds days, as we've mentioned in the past, and the whole thing around our health system consolidating and efficiencies around that. Threats, I think we've talked a lot about that: tariffs, federal state reimbursement cuts, OCA, and the sustained pressure of our pay. So, having said that, I think I will now turn it over to Jessica. If we haven't lost you, Jessica.
No, I'm still here.
Okay. And Jessica will lead us through our operating statistics.
Yeah, good evening. I'm going to lead us through some of the stats metrics first, and then we'll get into some of the expenses assumptions. But for discharges, you can see here we're moving from about 12,122 projected discharges for FY25 to about 13,200, which is an increase of 8.9%. 2.3% of that is due to volume increases, and then 6.6% is due to our outpatient observation days initiative converting to inpatient. Next slide. Discharges by payer. We did align our payer mix to be more in line with what we're seeing, the shift from commercial to government. So you can see that here in the budget 2026, our Medicare is about 48.4, Medi-Cal is about 25.9, both a little bit higher than last year, while our HMO is 2.4 and our PPO is 21.6, which is a little bit lower than last year. So we feel like our payer mix is aligned to what we're seeing. Next slide. Our patient days is moving from about 62,700 to 68,900 patient days, increase of 9.8%. Again, about 3.2% is driven by volume, while the 6.6 is driven by the observation days initiative that I mentioned. Next slide. Our average daily census is increasing 9.8% from 172 projected in FY25 to a budget of 188.9 days, all due to our patient day increase. Outpatient observation days, as you guys know, we have a big initiative and have built in some of that into our budget. So we do see a decrease of observation days from about 3,700 to about 3,500, which is a 4.7% decrease. We do think that's actually conservative. We actually think it could be more, but we kind of budgeted on the conservative side. Next slide. Average length of stay. We kept this consistent. We're running about 5.2 right now and project that to the end of the year. We kept it at 5.2, although as Ajay mentioned in the SWOT analysis, we do have activities and goals around ALOS. So we expect to see this decrease, but again, we wanted to stay conservative. Next slide. Deliveries. It's really consistent. It's a small increase of 0.7%. So we're moving from 1,647 deliveries to about 1,659. So it's remaining relatively flat. And then next slide is total outpatient visits is also remaining relatively flat of a 0.6% increase. You can see our ER is increasing a little less than 1%, and our non-ER is an increase of 0.4%. We have kept our trauma volume flat to what we project for FY25, so we don't have any increases built in for trauma. And again, we think this is pretty conservative, but definitely realistic. Next slide is our surgery. So our total surgery increase is 3.2%. You can see 3.9% of that is going to be in the cath lab. And that's mostly due to some of the procedures Ajay mentioned, especially the MitraClip. And then the OR is an increase of 2.9%. And some of that is due to some initiatives going on in gastro and ortho. Okay, so now that we got through some of the stats, let me go through some of our expense assumptions. Obviously, our biggest expense, salaries and wages, increased a little over 30 million this year. We did reduce some OT/DT in some specific areas for a little less than 1 million savings. But our FTEs due to volume increased about 15 million. And then the wage rate of a 5% for represented and non-represented represents almost about 15 million for those. So that really represents a big piece of the salaries and wages. Employee benefits increased 9 million. The pension and OPEB increase was a little over 3 million. And then we have the employee medical claims increased 3 million. And then the FICA increased due to the salary increase of about 2.3 million. Professional fees increased 3.5 million. Some of that, about 1 million of that, is for the new cancer center and the backstop and extra provider. We're also recruiting for a new maternal child health chief. Volume increase due to the full year for our mobile MRI. And then we have a little bit for the 340B retail program and those vendors. Supplies increased 5 million. Some of that came from the pharmacy side and is an increase due to the new cancer center and inflation in the pharmacy area. But the big majority of that is just variable supplies that grew with volume and a little bit in there for inflation as well. Utilities increased about 600K. That's due to PG&E increased rates annually. Software license maintenance increased 1.2 million. Some of that is increase in cost of an OrthoGrid imaging system for Dr. Saw, the Kodiak RCA solution software for NPR, and then just the annual fees and increases for our 70 plus applications across the system. Marketing and advertising increased $700K due to our brand rollout. Other expenses is relatively flat, a little bit of an increase of $200K. Most of that's in rental fees for the Mako robotic system for ortho and a software upgrade for our PET CT. Depreciation increased $1.5 million due to new assets coming on, offset a little bit by assets getting fully depreciated. And then purchase services and insurance increased $2 million, mostly due to insurance rate increases. Next slide, labor productivity. You can see our fixed FTEs are remaining relatively flat. It's actually a little bit down from what we're projecting FY25 to be. So fixed FTEs are going to be about 459 for FY26. Our variable FTEs, which flexes with our volume, is going to be about 1,362 FTEs, which is an increase of about 9.5%. But again, that's all volume driven and will flex with volume. So our total paid FTEs is going to be 1,821.6. But when you look at FTEs per adjusted occupied bed, we're staying relatively flat over the years. Paid FTEs is about 6.0 and productive FTEs per adjusted occupied bed is 5.2. And then finally, before we put it all together, other non-op, again, we stayed relatively conservative given the unknowns around some of the market performance that is not necessarily known. So some of the variances here you see are around those that we don't normally budget for. And then the other one that's causing us to be a little bit lower is the property tax revenue. We had a catch up in fiscal year 25 this year from 24 that we're not going to see next year. So it's going to be a little bit lower. And then our foundation continues to outperform what we expect. So they have a little bit more in there from a foundation perspective, 6.5 million from foundation, of which 4 million of that will go to the new cancer center. So those are all the pieces. I'm going to turn it back over to Ajay to put it all together.
Yeah. Thank you, Jessica. Moving on to the next slide. So this is basically the hospital budget coming together. We have, as I mentioned earlier, operating revenue of $685.2 million. And that's about $56 million more than the previous year. Our gross charges are about $150 million more, and contractual allowances, et cetera, go as per our models. In terms of the expenses, we're budgeting $39.4 million higher than last year at $435. Supplies, as Jessica mentioned, $5.4 million higher, $88.3 million. Purchase services at $36.5 million. Professional fees, $58.5. Depreciation at $44 million. And all other expenses are at about $26.7 million, for all total expenses to be at $689.9 million. That leaves us with an operating loss of $4.7 million compared to where we project FY25 to be at $6.1 million. So about $1.5 million better than the current projected fiscal year. Our non-op income is $20.7 million, which is about $6.7 million less than last year for the reasons that Jessica earlier mentioned. And the market does continue to perform better at this, we'll see a variance, hopefully a good positive variance. Could go the other way too, but hopefully not. So all of that results in a net income of $15.9 million, about $5.2 million less than the current year. On an EBITDA basis, we're about $3 million higher, which relates to about a 5.7% EBITDA margin. And on the last page of this is before we move to the capital budget, is the consolidated budget. This is where we bring in the affiliates. And so on this one, you'll see the difference here between the two slides is that at the second line from the bottom where we bring in the net loss of affiliate operations, that's going up by about $2.6 million year over year. And you can see how that is on the right side. Hospital has a net operating loss of $4.7 million. DEFCO, a positive $5.5 million, and WHMG, net operating loss of $35 million. So all of that brings us to a consolidated net income of negative $64 million, negative 2.3% margin, which we hope to outperform. But this is given how we're viewing the world right now, as we mentioned before, a fair representation of everything we could be.
Yeah, I think on that, as Ajay and Jessica said, the non-operating income, we've never budgeted for any increases or decreases from investment to that piece of it. But it really goes back to what has been discussed in terms of really looking at some of those operational efficiencies, revenue growth areas, looking at our ensuring aligned productivity with volume and all of that. So again, we've built some volume increases in though, but if we don't realize, we've got to flex, and there are a lot of different areas as we continue to grow programs that we need to do too. So, we understand that we need to move this that bottom line more towards the break-even side of things, and that is work that we're going to be focusing on over this next couple of
months. Any questions? Anything?
Questions from the board members?
And then also the work with revenue cycle is another area, I should say, that we are going to be focusing on too.
All right, Jessica, back to you on the capital budget.
Okay, so for capital, as Ajay mentioned at the beginning, we do have about $100 million budgeted for capital. Almost 90 million of that is in strategic, so a majority of that, and I'll go through those projects. We've got a lot of infrastructure projects in the works. About 1 million for rental TI improvements if needed, and about 9.2 million for routine maintenance break fix. Of the 100 million, about 47.7 million will be from the GO bond, while another 12.3 will be from philanthropy. Like the Cancer Center has some philanthropy dollars for that, and partnerships. We do have partnerships with UCSF that we are anticipating will contribute to the capital. So from an EBITDA or cash from operations, what we are expecting to use towards capital is right around 40 million, 3.9 million there. If you go to the next slide, here's the view of the strategic items. Again, we have a little bit of some projects that are just in closeout stage and just wrapping up final invoices. So there's just a little bit there, but you could see the majority of it is definitely our infill project as well underway. We expect about 40 million this year for that, which most of that will be GO bond funded. We mentioned the Cancer Center already. That's about 14 million this year that will come to the Cancer Center to get that wrapped up for their grand opening. We have an urgent care clinic opening, so about 2 million for that. The expansion phase 3 is 8 million. It's estimated at this point. I know there's still some work going on in design and stuff, so that could adjust a little bit. We have FOC in phase one for 12 million. We do think some of that could come from the revenue bond. So there is some of that 12 million could go towards the revenue bond. We just don't have the details yet. And the same with Warm Springs, 9 million for Warm Springs. But some of that we're hoping will come from UCSF contributions, as well as our own cash. But some of that could also come from revenue bonds once we get into more of the details. And then we have the ERP that was just recently approved for 5 million. And then we have the lobby refresh for about 300K and the exterior signage for 500K. So all of that's the 90 million. For maintenance break fix, we did prioritize these 6 projects that total the 5.9 million. Anything else, we do have a $1.5 million for contingency for things that break or we need to replace throughout the year that we don't know. But these 6 got prioritized. So we have outpatient CT for about 1.34 million, Stryker laparoscopic tower replacement for a little over $1 million, neuro microscope replacement for 888,000. An Exon 9100 cell count for lab is about 641K. An Epic anesthesia module implementation is 600K. And the Stryker neuro drills and power equipment replacement for 324K. So that was my final capital slide. So that's capital, and then I will turn it over to Ajay for cash metrics.
Thanks, Jessica, and I promise you this is the last slide.
And I think with capital, we understand in terms of days cash on hand in that piece, and so depending on how things go, we may have to do some further prioritization and see how delays are depending on where we stand. So we understand that some of the, these are important projects that we also have to continue to take a look at.
Yeah. Our cash metrics for the day, in particular the days cash on hand and the EBITDA, you can see for the hospital, we're projecting to be ending the fiscal year 25 at 128 days, and we're projecting for the 26 budget to be at 133. And the EBITDA for the hospital from 36.4 million to 39.3 million, as I earlier mentioned. On a consolidated basis, that's bringing in the health system. Our days cash on hand, we expect them to remain flat at about 116 compared to the current year, and our EBITDA to be somewhere pretty close to the current number of 14.5 we're projecting it to. Any questions?
Any questions from the board member?
Yeah.
Comments from the board members?
I'm always impressed with the sincerity of the approach.
Thank you.
I think that is really, really important. We just can't count, especially look for weight revenue kind of thing.
Yeah.
We've got to be very careful.
Yeah, we agree. I think there are ways that we can outperform, and I think we will, but I think this is a good place for us to be given all that in the environment and in the health ecosystem, for sure.
Well, I wanted to express my appreciation to Ajay, Jessica, your whole team, Kimberly, all of your management staff, in going through this monumental effort. It's a real challenge in these uncertain and challenging times. It's a difficult process. It reminds me of one of Yogi Berra's quotes, which he said, "It is tough to make predictions, especially about the future."
That sounds like a yogiism.
It's a very good quote, very applicable to what we're dealing with here, because we have a lot of uncertainty, as Kimberly said.
Yeah.
The only certainty is uncertainty and a lot of challenges. And when I look at a budget, what I really see is a navigational map. We are taking this ship with precious cargo and all hands on deck, and we're heading out into rough seas and stormy weather. Budget will let us know whether we're on track or getting off track. Just stay in the right direction. But clearly, we're heading off into uncharted territory in the years ahead. But what we want to do is make sure we're safe and stable, protect that precious cargo that this institution cares for year after year. So I really appreciate the great work that all of you have done.
Appreciate it, and we really appreciate the board support.
Yeah, thank you.
One of my concerns in the uncertainty would be beyond Medicare and Medicaid cutting, funds being cut. NIH grants are being cut.
Right.
And as you know, UCSF is one of the largest recipients of NIH grant in the country.
Mhm.
And if that goes, our future relationship about Palm Springs, and we are so dependent on them at this point, I would be really worried about, I hope it don't be too shaky.
Well, I think we are indeed fortunate as an institution to have UCSF as one of our partners. They're perhaps the premier medical institution in this country, and I think we're very blessed to have that working relationship with them. They obviously are going to have their challenges.
Like all of us.
Yes, indeed, but they do have the people of California behind them. I think UCSF has a wonderful reputation, and no matter the difficulties that years will show, I think they will remain strong. I mean, they've been around for a long, long time, and have grown tremendously, and that fruits of that growth we see every day in the way we're able to care. So I think all sectors of society are going to face challenges. I think we have to do our best, and with the help of wise counsel from management and people to understand how to remain afloat and safe and continue our mission.
And I think they're all very good points, and I think that's some of the uncertainty, and absolutely, I think all hospitals and health systems are looking at what those priorities are and how to stage them in the right way. And so this is all going to be an ongoing conversation, and as time goes on, we may know more, or we may have to continue through wading through some harder territory. So I think they're all good points. We do understand them. We understand that we may be coming back and having other discussions in certain areas, but this is sort of this map, and I appreciate what you said, because I think it's very appropriate as we go into this next fiscal year, and definitely want to thank Ajay and Jessica and the team and this team here and all of the executive team for the work that's been done. So the board support. So again, it is sort of our best guess in terms of the uncertainty, and it's an overall map for us for this next year. So thank you. And I'd like to ask maybe if the board would...
Well, I was going to take the chair's prerogative.
Yes, thank you.
To take an action item out of order, and I'm hoping we can consider action item A. So Dr. Eaton.
Mr. President, I move for the adoption of resolution number 1273, the consolidated budget estimate for years 2025-26.
Thank you. Do we have a second? Second from Dr. Stewart. Sheriff.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen?
Aye.
Director Wallace?
Excellent. We have a budget.
Thank you.
Go to it.
Thank you.
Yes.
Yes. Thank you. Thank you very much. Thank you, Jessica.
Great job, Jessica.
Thank you.
Have a good evening.
All right, we have presentation number 2, also a very important topic, our community health needs assessment. As you know, about every 3 years, we present this to the board for a recommendation for approval of the findings, and then we come back later on with an action plan around it. But it's my pleasure to introduce this evening Angus Cochran and also Kayla Gupta are with us, so I will do a short bio on each of them. Angus Cochran is our Chief of Community Support Services. He's been with the health system since 2006 and currently, as I said, serves as Chief Community Support Services. In this role, he is a liaison to the Service League and manages community outreach and the Health Insurance Information Service. He is also responsible for government relations. He earned his bachelor's degree from UCLA and a doctorate from Columbia University. And I think everybody knows when out in the community, everybody knows Angus Cochran. He's in all of the different events. So thank you, Angus, for being here this evening. And then also Kayla Gupta, also who is our community outreach manager, is very much spends the majority of our time building those collaborative relationships with organizations in our community. She has been with us since 2022. She is responsible for the health and wellness programming and the Washington Wellness Center. Before joining Washington Health, she worked with Sutter Health as a community benefit coordinator. In this role, she managed the community health needs assessment and grant-making program in San Mateo and Santa Cruz counties. She earned her bachelor's degree from the University of Pennsylvania and master's degree in public health from Emory University. She is married with one very cute young son. All right, I'll turn it over to Angus and to Kayla.
Well, thanks so much, Kimberly. It's a great pleasure to be here this evening. Hello to the district board. Thank you for that nice introduction. If it seems like we were just here talking about this, you might be right. We were, rather than doing this on a 3-year cycle this time, we're actually accelerating our next community health needs assessment. We were here last in 2023, and so we're back 2 years later instead of 3. And the reason for that is really that we wanted to get back into the collaboration with the rest of the East Bay hospitals and health systems and doing our assessments together. That partly allowed us to share the costs of the study with our partner institutions, and also gave us access to our larger data set and to more focus groups and key informant interviews as well. So we're happy to be back in the collaborative that Kayla managed and wrangled this time round. You'll see from the results of this year's community health needs assessment are largely consistent with the one from 2 years ago, but there are some interesting new health conditions that have surfaced in the community that kind of show where the community has gone in the last couple of years. And so this is really intended as a very quick synopsis of the 216-page report that will be posted to the website at the end of this month. Before I turn it over to Kayla, I just really want to thank you, Kayla, for all of your hard work on this. It's not easy working with 12 or 13 different partner organizations, but you threw your heart into it. And I also want to thank Kimberly and the executive team for supporting this work. I know it's required by regulation, but many other institutions do only really pay lip service to it, whereas we really do a lot of work in this space. So with that, I'll turn it over to Kayla to dive into the presentation.
All right, thank you so much for that introduction, Angus, and thank you so much for the district board for allowing us to present this to you this evening. Let's get started and move on to the next slide. So today's presentation, we're going to cover what exactly is a health needs assessment, how do we go through the process, and then we'll really take a look at what we found this cycle in 2025 and do a deep dive into each of the identified key health needs, wrapping up our presentation today with a summary of the findings for each of the cities within our district. So the CHNA at its core is really something that helps provide important insights into the health of the community. It's something that's federally mandated to happen every 3 years, but as Angus mentioned, this time we decided to increase our timeline and do it in 2 years for partnership reasons. And the CHNA really is what allows Washington Health to develop strategies that tackle critical health needs and improve the health and well-being of our district overall. If we move to the next slide, we can see an overview of the process of creating our CHNA report. It's quite a long process that includes both data collection and analysis. Our team actually started working on this about a year ago. And after analyzing and synthesizing data, we create a community health needs list that outlines the top needs in the district. So let's move forward one slide. As Angus mentioned, this is required to be done every 3 years. However, you'll notice that our last report was published 2 years ago in 2023. So by undertaking this cycle 1 year early, it allowed us to get on the same timeline as our other local hospitals and more strongly collaborate with Alameda County Public Health. So this slide just shows all of the hospitals that we partnered with for this 2025 CHNA report. Moving forward, we can take a look at our data sources for this report. One good news that I have to share with you is our consultant group was able to refresh all of the data that was used in our new report, in addition to incorporating a lot of additional resources for data analysis. In total, our CHNA included 300 data indicators compared to around 125 that we did last cycle. And almost half of these indicators provided data that was specific to cities within our district. Looking at the qualitative data that we collected, over 200 participants provided input for this report. This is compared to 50 participants for our 2023 report. And input took place in two main ways, through key informant interviews and focus groups. One thing that was very important when doing our data collection was that we wanted to make sure our focus groups captured the voices of many different individuals, especially those representing vulnerable populations like our unhoused, individuals with disabilities, low-income populations, refugees, and racial minorities. And the next slide talks a little bit about the methodology of how we determine a health need. This is pretty well defined. It's been adopted by all of the hospitals in our collaborative. But in the interest of time, we're going to just skim past this really quickly. And if you have more questions about methodology, we're happy to answer those at the end of the presentation. So let's start out by looking at a snapshot of our district. Our population of the healthcare district is just over 340,000. And as we all know, it's very diverse community. About 54% of households speak a language other than English in the home. I just wanted to point out an extra note about our population. If we move to the next slide, you can see that when we reported our district population back in 2023, the population was a bit higher. And so we've experienced a 2% drop in residents in the district since 2020. However, this population change is consistent with what we're seeing across Alameda County overall, where the population dropped about 2.8%. The largest population decline that we saw within our district was in Union City, where we saw our population decline about 6% since 2020. Looking again at some more demographic information, as I mentioned before, our healthcare district is incredibly diverse. The majority of our residents are non-white, with Asians making up over half of our population. And nearly half of the residents are foreign-born, with 1 in 5 speaking limited English. Furthermore, we have data, if we go to the next slide, that supports that what we already know to be true. We're located in a really high-cost area. The United Way calculates that the real cost measure, or the income that would be required for a family of 4 to meet their basic needs, would be over $120,000 in Alameda County. Within our district, more than 1 in 5 households are living below this measure. So cost of living is a large concern. And one last thing, before we jump into our new health needs list for the 2025 report, I just wanted to take a moment to quickly review the health needs from last cycle. So the key needs from our 2023 report, which were listed in rank order by community priority, were behavioral health, housing and homelessness, economic security, diabetes and obesity, healthcare access and delivery, heart, stroke, respiratory health, and cancer. So moving forward now, we can see our health needs list for the 2025 assessment. And these also are listed in rank order by community priority. We have economic security, behavioral health, healthcare access and delivery, inequity and discrimination, cognitive decline, diabetes and obesity, heart, stroke, cancer, maternal infant health, and unintended injury. In total, there are 4 new needs on this list compared to last cycle. Those are highlighted in red. And 2 of the needs from our previous cycle, you'll see, have now dropped. So respiratory health is no longer on the list, and housing and homelessness is now included within economic security. So let's dive into these specific health needs, the first one being economic security. Economic security, for the purposes of our report, includes education, housing stability, and food security. And it was the highest priority health need that came up in our focus groups and interview discussions. In fact, it was talked about in 98% of our community discussions. And high cost of living was one of the key themes among our CHNA participants. Community members also expressed concerns for immigrant populations that face additional barriers due to documentation issues and potential language barriers. There's also a large concern for seniors that are living on a fixed income. If we move forward, we can take a look at some of the data highlighted in our report, where we break out median income by city, by race. The higher the dot is on the chart, the higher the income. And across the board, we can see that there are disparities, specifically with our Black population having the lowest earning attainment. As I mentioned, housing and homelessness is wrapped into economic security for this report. And I do have some good news. In Alameda County overall, we do see that the population has decreased in our homeless population since 2022. We've also seen decreases within our district cities as well, where homelessness dropped by almost 300 people in Union City and 136 people in Fremont between 2022 and 2024. That being said, we still do see racial and ethnic disparities present within our populations experiencing homelessness. The left side of the chart shows the share of the population by racial and ethnic group. And then as you move to the right side of the graph, it shows the share of the homeless population by racial and ethnic group. So we can really see our Black and Native American populations overrepresented in the homeless population overall. Let's take a look at our second health need now, which is behavioral health. So behavioral health includes mental health, substance use, and community safety. And this was prioritized in 90% of community discussions. In fact, during the pandemic, we saw a 75% increase in reports of psychological distress across the district. And as we heard from our director of Alameda County Behavioral Health Services, Dr. Karen Tribble, at our symposium on Friday, there is a critical shortage right now of behavioral health professionals in the county, which really means that we don't have enough providers to address this increase in demand. The good news, however, is that in general, behavioral health indicators in the district look good when we compare them to the county. However, one indicator where we do see unfavorable outcomes between the district and the county is for severe mental illness visits in Newark. So there's that chart that shows that one indicator, which is severe mental health illness, ED visits, which are significantly higher in Newark. Let's move now to our third health need, which is healthcare access and delivery. So healthcare access was prioritized by half of all interviews and focus groups. And there was a big emphasis on the fact that mental health and dental services are 2 specialty care services that many community members have difficulty accessing. There's also an emphasis on the importance of being able to receive culturally relevant care, particularly in the language that they speak. So if we move forward, we can see, on one hand, insurance rates in our district for our district residents are pretty good. Our residents are well insured. However, if we move forward, despite having insurance, we're seeing a trend where it's really increasing difficulty for accessing care, which has been on the rise. So right now, about 25% of our population reports delaying or having difficulty obtaining care. Our fourth need is inequity and discrimination. So slightly less than half of all of our participants expressed concern for inequity and discrimination. And this is, was called out in all settings. So workplace, schools, housing, healthcare, and multiple forms of discrimination, whether it's related to race, gender, sexual orientation, or immigration status, can have negative impacts on overall well-being and health. One way that we're able to look at this, if we go to the next slide, and see these inequities at play is in life expectancy rates across the district cities and Alameda County. So this table here shows life expectancy at birth by race, and the dark green values indicate highest life expectancy. The dark red values represent lowest life expectancy. And indicators show that life expectancy rates are lowest for residents in all 3 cities and the county for Black individuals. Moving on to our 5th health need, is cognitive decline. So cognitive decline, as I'm sure you're aware, refers to a reduction in mental abilities greater than what is expected for a person's age. And while we recognize that many conditions are related to cognitive decline, for the purposes of this report, Alzheimer's disease is what we really have the data for. So it's mostly what we'll be talking about. Alzheimer's disease is the 5th leading cause of death in the county, and associated risk factors such as diabetes, high blood pressure, and obesity are all areas of concern in our healthcare district. Additionally, we've heard feedback from community members that it's difficult to connect to geriatricians or providers that specialize in working with older populations. We also see racial inequities that arise with Alzheimer's disease. And so when we look across the 3 district cities, we see that Alzheimer's disease mortality is highest among our Black population compared to other races and ethnicities. In Fremont, mortality rates for Black individuals are almost 3 times as high as all races, and in Union City, Alzheimer's disease mortality is over 2 times as high for Black individuals. Now we'll take a look at diabetes and obesity, our 6th key health need. Similar to previous CHNA cycles, diabetes and obesity continues to be a key concern in our district. Among individuals that talk about diabetes and obesity, many express concern about the affordability of healthy foods. Additionally, we heard discussions about how unhoused individuals are unable to manage their disease without a stable home. And when we look at the data on the next slide, we'll see that diabetes prevalence continues to increase year over year, almost doubling in the last 14 years. Diabetes rates are consistently worse in the healthcare district than the county, and the prevalence of diabetes is highest in Union City when compared to Fremont, Newark, and the overall county. Racial disparities also exist, which we can show on the next slide when we look at diabetes prevalence. In these charts, the colored dots towards the right of the chart are worse than those on the left, and we can see that diabetes prevalence is highest among the white population in Union City and around double the rate for the Latino population in Fremont. Looking at data for children and teens, we also see troubling trends over time. Yellow shading in the tables on this slide show data that is worse than the county by 5% or more. And childhood obesity rates are consistently significantly worse in Newark and Union City than the county. Our 7th health need is heart and stroke. So cerebral vascular conditions continue to be a concern in our healthcare district. Issues such as heart disease, stroke, heart attack are among the top causes of death in our county. Participants mentioned heart disease in focus groups when they think about the links between stress, mental health, and heart health outcomes. And they express difficulty affording food that would support a heart-healthy diet. Like last cycle, we can see on the next slide, Union City continues to be impacted by cardiac conditions. In addition, this cycle, we start to see concerning data in Newark as well. Almost all of the indicators shared on the table in this slide are worse than the county by 5% or more, which is indicated by the orange shaded boxes. Looking more closely at Union City specifically, we see that the city is worse than the county on 12 out of the 14 indicators related to heart and stroke. And stroke mortality, which is not listed in this chart, continues to trend higher at around 20% more than the county's rate. I also wanted to take a moment to dive into the data for Newark on the next slide, where we can see 5 conditions that are becoming more worrisome. Hypertension ED visits, hospitalization for ischemic heart disease and cardiac dysrhythmia, ED visits for ischemic heart disease, as well as cardiac dysrhythmia mortality rates. We'll now take a look at our health need, our 8th health need, which is cancer. So cancer qualifies as a health need in our CHNA because of the statistical data that we see around racial and ethnic disparities, and we'll further explore that in the coming slides. In 2022, cancer was the #1 cause of death in Alameda County. And when community members talk about cancer, they're often expressing concerns related to financial burdens of cancer. So that's not just including the medical costs for treatment, but also loss of income due to time away from work. When we slice and dice the data by race and ethnicity, we can see once again that our Black population, the blue bars in this chart, are disproportionately impacted by the condition, especially in Union City and Fremont. Cancer mortality rates among the white population in all three cities are also higher than the county's rate. And if we look at cancer mortality and hospitalization by city, we can see that lung cancer mortality is highest in Newark, and colorectal cancer hospitalization is highest in Union City. Union City also has higher rates of breast cancer hospitalization than the county as well. Our ninth health need is maternal and infant health. So all cities in the healthcare district have worse rates of infant mortality than the county. Premature birth rates are much higher for Black mothers in Fremont and Union City. Not only that, Black mothers in Alameda County face worse rates of maternal morbidity than the state as well. When community members speak about maternal and infant health, they focus on the economic constraints that make it hard for mothers, both before and after baby, to take care of themselves and their children. Newark and Union City have the highest rates of infant mortality in the district, and Fremont's rate for infant mortality is lower than the other district cities, but still higher than the county. I did just want to note that thankfully within the hospital itself, Washington Health sees a much lower infant mortality rate of 0.81 per 1,000 live births. And now our 10th and final key health need is unintended injuries. So this is one of the new needs on our list for the CHNA. And unintended injury is the #1 reason for preventable ED visits. These include things like falls, drownings, motor vehicle accidents, and pedestrian-related injuries. And this is really timely with the opening of our trauma service last year. The chart on the next slide really drives home the point that unintentional injuries are causing preventable hospitalizations. And when we look at data by race and ethnicity, which is on the next slide, there's significant disparities, with the Black population having a higher frequency of deaths in Fremont and Union City from unintended injury. And so as we move into the next part of the presentation, I'm going to turn it over to Angus to take a look at how we've aggregated the data for the three cities.
Okay, thank you, Kayla. So we're kind of rounding the last bend here and coming into the home stretch. We wanted to show the data aggregated for the three cities, partly because that's kind of how our residents think about it. They think of themselves as being a resident of a city, not necessarily an ethnic group, or in addition to being an ethnic group or a resident of the district. And this also shows a lot the difference between the cities and the county. Because we rejoined the collaborative, we had access to far more disease state data. And so you'll see there are more conditions in this than there were in the 2023 report. Basically, with these three slides here, the vertical line at 0% in the middle of each of these graphs shows the county average. So all of the bars to the left of that line show where each of the cities is doing better than the county average, or where the incidence of a particular disease state is lower. So for Fremont here, you can see that for 93% of our disease indicators, it's doing better than the residents are doing better than the county. Likewise, in Newark, for 80% of the indicators, they're doing better than the county as well. And I think this is a really stark illustration of how Union City still continues to struggle with its health. The residents they only beat the average about 56% of the time. Next slide, please. So we thought we would just look in a little more detail at some of the health indicators that are worse than the county average for the three cities. For Fremont, it's emergency visits for Alzheimer's and dementia, hospitalization for ischemic stroke, ED visits for cardiac arrhythmia or dysrhythmia, pedestrian mortality and unintended injury, and hospitalization for stroke. Next slide, please. The 14 indicators for Newark that are worse than the county average, predominantly they're associated with heart disease, diabetes, and obesity. However, there are also indicators here that are worse than the county average for infant mortality, emergency room visits for drug and alcohol use, and lung cancer mortality. Next slide. And then finally, these are the 31 indicators in Union City that they fell next to the county average. I think as we saw in the 2023 study, most of these conditions are related to heart and stroke conditions. But as you can tell by the sheer number of conditions on this list, residents in Union City are having challenges maintaining their health. So that's kind of the final snapshot of our district. Next slide, please. And to wrap up, basically, the next steps for the 2025 CHNA are we would ask the board to accept the findings today of the study. We will publish the final CHNA report to the website by the end of this month. And then Kayla and I will take our roadshow on the road, and we will be going to city councils, school districts, service clubs, anyone who will listen to us, giving information out about what the state of the district is in terms of their health. Then, as Kimberly mentioned, we'll be back in the fall with our health improvement plan for discussion and approval, and that should be up on the board on the website by the middle of November. Thank you so much for your time, and if there are any questions, we're happy to try and address them.
Great. Thank you, Angus and Michaela. Any questions, comments from the board? This is very interesting information.
I just think it's really, really an important thing. As a community hospital, this is our real business. We truly need to serve our community, health, well-being of everybody else, everybody around us. There's no better way to start than to get an idea of what's going on out there.
Mm-hmm. Yeah, I wish, some of these numbers could be communicated to the community.
Yeah.
So that the people are aware.
Yeah.
So
That's a good point.
And, the variations, Angus, especially dementia. Recently, there was a report, I think last week, that regional variations, they reported diagnosis of dementia is much higher in Northwest, Southeast, and Rocky Mountain area than in Mid-Atlantic. So this was just a last week report. So within our district, who knows, there may be a regional variation because of factors that are not known.
So it is very important, as you said, to get this information out to our community and talk about it, and to say, how can we partner together with other organizations and other people, hospitals, nonprofits, others in this community, groups, to do that. And I think that's where Kayla and Angus need to, as they've done in the past, to continue to go out and look for partnerships, because we can't work in our silos in order to make improvements. We all have to work together, and we'll be stronger together too.
So because, I think one of the numbers showed was increased incidence of breast cancer and colon cancer in Union City. I think if the Union City population is made or educated on this, there may be more people ready to take preventive steps, like mammogram or to colonoscopy.
Yes.
So I think it's very important to educate those numbers to the community.
Yeah.
Well, and Kayla's done a great job this year. I'm sorry.
Go ahead, Angus. Go ahead.
No, I was going to say Kayla's done a great job this year of building partnerships in Union City. And one example of this was we did this presentation in front of the New Haven School District Board a couple of years ago. And they took the information about childhood obesity and heart disease, and they built it into their wellness plan for children in their district, which meant that their nutrition staff were involved, the exercise staff were involved, and so on a local basis, I think we are seeing we're making some differences, but there's a lot more work still to do.
I think you bring up a very important point as far as educating the public, and especially educating the kids in the schools about these disease states so that they can start to have a better understanding of them. And as we know, kids can be a very powerful motivators for their families. So that's a powerful mechanism. And as you approach your action plan, I really want you to think about, where we can make the biggest improvement for the funds and capital and energy that we have. We have a limited amount that we have available, and as you can see from the long list of diseases, tremendous amount to work on. So what we want to do is figure out where we can be the most effective in moving the needle of health in Alameda County. Personally, I was very, very encouraged to see that your assessment recognized cognitive decline as one of the major problems, because it is certainly something that I see day in and day out in my practice. It's a challenge. And from what Dr. Epen said, you know, there is disparities, but I think we also need to learn how to recognize it more easily. So understanding what it is and how to recognize it is the first step into approaching treatment for it, and evaluation and treatment for it. And it is, as our population ages, you know, we're doing good work. Cardiac, stroke, cancer, diabetes, all these other entities, people are living longer. And many of them, as they age, get into the problems of Alzheimer's, dementia, cognitive decline. So I hope we're able to find some good, effective action plans that we can move forward for our community to help address not only that issue, but all the other issues that you've addressed. So thank you very much for your presentation.
And there's one more thing that I probably would like to see is the vaccine uptake, immunization uptake in all the cities, especially because of this outbreak in measles that has started off from West Texas. Already more than 1,500 people are affected. So if you find a pocket of low immunization rate in one of our districts, we could at least be prepared if there is an outbreak. So I think, this is something that's really good. That might help.
Yeah, I'm glad you pointed that out, Dr. Epen. That's something we'll keep an eye out for, and we can talk to the Alameda County Public Health folks about as well, because I know they collect data on that, and perhaps they can break it down by zip code or by city at the very least. So we'll definitely do some work on that.
I think an important part of that is to know whether the local public health officials can have access to aggregated data in the state vaccination database. Yep. All of us, as we get our vaccinations, those vaccinations are reported to the state. We personally can get access to our own data. Yep. Pharmacists that we're seeing for vaccinations can get access to that. The question is whether the public health officials can get access to look and help us understand what the vaccination rates and understand where vaccination hesitancy is an issue. And then
I think for children, I think there's a registry now. So pretty much all the clinics are attached to the registry. So any shots that are given to a kid, it goes into a central registry for the last maybe 7-8 years.
Thank you. It's very helpful. Kayla, I think we have our marching orders.
Yeah.
You got a lot of work to do.
Really appreciate it.
Thank you for the good work you're already doing. Thank you.
Thank you. We're eager to hear what you come back with us in the fall.
Stay tuned.
We'll do.
I think there's an action item here too. Thank you.
Yes.
Yeah, I know. I'm going to take another item out of their agenda's order and ask Dr. Epen to present action item B.
I move the Board of Directors vote to accept the findings contained in the 2025 Community Health Needs Assessment.
I'll second that.
Motion is second. Cheryl?
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Aye.
Director Wallace?
Thank you.
Thank you.
Assessment is accepted. We'll see you in the fall.
Thank you so much.
Thank you.
Thanks.
Thank you both very much.
Yes. Okay, we'll now move on to the report section of our agenda, and we have Dr. Mark Soleil. Mark. Good evening.
Good evening, everybody. Can you guys hear me okay?
We can hear you okay, but I want to make sure you can hear me.
I can. Thank you.
Good.
I've heard the whole meeting.
I know this is your last presentation before the board as Chief of Staff. And I just want to express my appreciation on behalf of the board and the gratitude of all of us for your excellent work over the last 4 years. First 2 years as Chief of Staff-elect, last 2 years as Chief of Staff. You demonstrate excellent leadership, calm, thoughtful, but really effective leadership. And so we're very happy to have had you as medical staff, Chief of Staff the past 2 years. Now, my only hope is that Aaron Berry has learned from you. And he's got some big shoes to fill, but I think he's up to the task, but the next 2 years will tell us.
Well, I agree.
Thank you again for your great work.
Thank you so much for those kind words. That really means a lot to me, and I do appreciate it. It's been an honor to serve in this role, and I'm going to continue on as the immediate past Chief of Staff. I'll be the chair for the PPAC committee. I'll still be on the Leadership Council. But my role so far as Chief of Staff has really been a growing opportunity. I've learned a lot. I've really enjoyed working with everybody here on the board, administration, Ms. Hartz, and it's nice to know that the work has been noticed. And as far as Aaron, I have no doubt that he has learned everything he needs to learn, that he has the ability to carry on. And I'll be there to support him, of course, but I don't think he'll need much.
Good. Well, thank you. Okay, so you can tell us your report.
Thank you. Well, as often happens at these meetings, I'm following things that are hard to follow. Those are excellent reports. As always, I want to express my appreciation to Angus and Kayla for that excellent report. For that whole, the budget, for Ms. Hartz, the board, everybody involved in the financials, for carrying on that monumental task of managing all that money and keeping the hospital afloat and keeping it growing even, not just afloat for our community. I really appreciate it, and it is noticed. Off to the report. So we have a grand total of 671 members, medical staff members. Of those, of those, about half, again, are active, 364. 2 are administrative, 38 are advanced practice providers, 100 ambulatory, 8 consulting, 12 courtesy, 2 leave of absence. We have 84 provisional active, 10 provisional advanced practice providers, 48 provisional consulting, and 3 that currently have temporary privileges. Several things were approved by the MEC and that are, may have already come to the board, but need to come to the board. The Medical Executive Committee, in its meeting on May 19th, approved the medical staff rules and regulations changes, especially with the creation of the residency category. They've also approved the medical staff credentialing policy regarding proctoring, and medical staff bylaws as it applies to provisional medical staff category. And those documents should be in your package. Any questions about any of that?
No, we already took care of that, Mark. Thank you for putting that on our agenda.
Well, great. And I missed that part. And then we have the medical staff dinner dance coming up, where I will at least informally hand the staff over to Aaron, and I'm looking forward to seeing everybody. It should be a fun evening. We have a lot of people that have replied to that. The list is growing. And I think the final thing I wanted to mention was the new badges that the hospital is coming up with. We're working hard to get everybody on board. I think most of the active staff that we see on a regular basis have gotten their pictures taken. We have a few stragglers that we're trying to chase down, and eventually we're going to have to suspend their access to the lounge and maybe to other things as the stick or the carrot, whichever way you look at it, to hopefully get them on board. And that is it. That is my final report, at least as Chief of Staff. I'm hoping to see you for other reasons.
All right,
thank you very much.
Thank you, Mark. We'll see you on the 28th.
Yeah,
it should be a fun evening.
Have a good evening, everybody.
Okay, you too. Okay, we're going to move on to our Service League report, and instead of Sheila, we have Jill Zeman.
Yes,
Simon.
hi, good
Thank you,
evening,
Jill.
and greetings from the volunteers. As you said, I'm filling in for the Service League President, Sheila VJ, who was not able to be here tonight. And my report is as follows. In May 2025, 232 Service League volunteers contributed 1,887 hours of service for the hospital. Their steady involvement continues to provide essential support to patients, families, and staff. On May 20th, we hosted a mini orientation for 6 adults in the Service League office. The attendees were eager to learn more about the opportunities available to volunteers. A larger orientation followed on June 2nd, welcoming 48 new volunteers, 5 adults, 15 college students, and 28 high school students. On May 15th, the Service League participated in Washington Health's Celebration of Life event honoring cancer survivors and those impacted by cancer. At our information table, we offered heart pillows, tokens of comfort and care, generously donated by Sherry Tillman from the Church of Jesus Christ Latter-day Saints. High school students' interest remains strong as summer begins. We are working closely with students and their families to ensure a meaningful experience that supports their development and the Service League's mission. Lastly, we would just like to thank the health system for inviting the volunteers to all the festivities during Health System Week. We loved our lunch at the food trucks, and we are getting great feedback about the beautiful Washington Health jackets we received. Thank you for always including the Service League volunteers in these celebrations. And that concludes my report. Thank you.
Well, thank you, Jill. Any questions or comments for Jill? Yeah, I think we all give a double thumbs up.
Thank you.
Thanks again. And really nice to see those orientation sessions with new volunteers coming in. I think it's a wonderful thing.
Thanks.
Take care. We'll see.
Thanks, Jill.
Thank you.
See you later. Okay. Ajay. Back to you. Finance report.
Thank you. Bringing it up, sure. Okay, I'll just start. Our April was in line with the previous few months in terms of the operating indicators. Our daily census has been running over budget, as it was this month, by 16.7 patients per day. Our discharges are running higher by 136, 1072 for the month. Patient days were higher by 502. And outpatient observation days are down 208 from budget to 209. And our length of stay was a really good news, down to 5.16 versus a budget of 5.3. Continuing on with the operating indicators, the CMI continued to be also strong, up almost 0.04% on that. Deliveries up 14, surgical cases, and we'll get into more details in the next couple slides, down by 8, cath labs down by 8, outpatient visits higher by 273, and ED visits lower by 303. Trends fairly similar to previous months, and I think that has carried on. In terms of surgical cases, of the 8 that were less, majority of them were lower in orthopedics and in the other area, and we were higher in endoscopies, on the cardiac service lines and the neuro service lines. On the cath lab side, as I mentioned earlier, we were below by 8, and peripheral vascular was below by 6, and non-vascular IR below by 11. Positives were in the cardiac service line and the neuro IR suite lines. Moving on to the operating indicators, and And this is, as you know, this is mostly a rehash of what Kimberly went over last month on the operating indicators. Our productive FTEs we're flexing well, 16.8 under our budget. Non-productive FTEs, 9.5 under, and total FTEs as a result, 26.3 below budget. And our FTEs per adjusted occupied bed, 5.77 versus a budget of 5.92. Moving on to the financials and the revenue line items. Our gross revenue was $9 million higher than budget at $223 million. This month we actually changed, as we've talked in the past, our contractual model to with Toyon. So there was an intermediate change, if you remember, I mentioned earlier, and then there will be another change down the road where we make it much more computerized, digitized model, which will probably happen the start of the next calendar year. So what this has done is that, and you'll notice here that our contractual, it's flipped a little bit from our bad debt to our contractual allowances. So our contractual allowances are a little higher, and our bad debt is a little lower. Overall, it's keeping us fairly flat, but I think it's now representing better how our actual payer mix is performing. So I think I just wanted to point that out. Overall, our deductions as a percentage of revenue, including the contractual as well as the provision for bad debt, 76.61% versus the budget of 76.99%. Moving on to the next slide on our summary of operations. Our operating expense, so all of that resulted in a net operating revenue of $54 million versus a budget of about $50.7 million. They were higher by about $3.3 million. Our operating expenses, unfortunately, were higher by about $3.6 million than the budget. So 54.9, 55, basically against 51.3. That resulted in a loss of $910,000 versus a budget of a loss of $653,000. On our non-operating income, we were fairly close to budget. We were at $2672 versus budget of $2683. So overall, we had a net income of $1.76 million versus a budgeted gain of $2.03 million. 3.3% actual versus 4% on the budget. Any questions about this? Very good, thank you. Okay. The GASB sort of follows that. It's just geography changes. I won't spend a whole lot of time on this. You guys have seen enough numbers for today. And the last slide here is the EBITDA, which I'd like to point out again. Our EBITDA for the month was $2.6 million. Budget was 2.8, 4.8% versus 5.6% on a year-to-date basis. Similarly, we are 6.3%, a little below budget at 7.5. And net income was $1.76 million, as I mentioned earlier. 2.03 was the budget, a little below that. So we were a little below budget. On a year-to-date basis, our net income is $20.9 million versus a budget of $14.7 million. Take any questions?
No, I think this just reflects the winds are strong and the seas are rough.
You're right. And our operating, the place is full. And I think both of my colleagues here will attest to that. But, our payer mix is suffering. There are things happening within our model that is continuing to affect our top line as well as the costs of the trauma program and other things that we've taken on. And in particular, actually, our OPEB and our pension costs and the health benefit costs. If those had been normal and per budget, we'd actually be far above budget right now. Those are fortunately not controllable at this point in time. Those are what they are.
Understood.
Until we start thinking about different ways.
It's just frustrating to see such good numbers in so many areas, and then the bottom line's not so good.
Yeah, I completely agree.
Okay.
Well, I think June is going to be relatively the same or similar. We still have wind strong and seas tough in terms of it. All right, in May, I'll start with outpatient observation days trend. Outpatient observation days was 197, 237 days, or 54.7% favorable to the budget of 434. And so we've really seen, since we've started the initiatives in March, a much more consistent and predictable in terms of observation. I do just want to thank again Dr. Raja Sadiq and his team that have been working hard on observation days with Mary Beauron and her team. So we just want to thank them at this point, and we're going to continue to focus that for next fiscal year. Moving on to our total gross revenue trend, total gross revenue came in at $233.3 million for May. It was favorable to the budget of $220.8 million by $12.5 million, or 5.7%, and favorable compared to May of 2024 by $21.3 million, or 10%. And again, looking at year-to-date revenue was favorable to the budget by about 2.3%. Moving on to trauma cases, continue to see around similar numbers as last month. Trauma cases for May came in at 151, which was favorable to the budget of 113 by 38, or 33.6%. And year-to-date cases were favorable to the budget by 484, or 39.7%. Again, the same trend, we're seeing less inpatient cases compared to budget and more outpatient cases. Looking at our trauma cases by activation code, we had, as I said, 151, and you can see it's broken down by 7 alphas, 34 bravos, and 109 deltas. In terms of the types of cases, again, we had about 50 falls. The other number that we saw more of than in the past seems to be, we had about 24 motor vehicle crashes, so more in terms of seeing that. But again, and also then about 57 general trauma cases. Looking at the gross revenue for trauma, came in at $16.6 million for May. This was favorable to the budget of $14.3 million by $2.3 million, or 16.2%. And year-to-date, we're favorable to the budget by $30 million, or 19.1%. Inpatient gross revenue, as I said, in terms of cases, were below budget, but overall, and for May, with inpatient trauma gross revenue of $11.1 million for May was unfavorable to the budget of $12.6 million by 11.9%, but outpatient trauma gross revenue of $5.5 million for May was favorable to the budget by $1.7 million, by about 200. So the budget was $1.7 million, so it was favorable by $3.8 million, or 225%. So again, we've seen that shift compared to what we had budgeted. Moving on to inpatient gross revenue, came in at $141.7 million and was favorable to the budget by $17.4 million, or 14%. And 19.7% higher than May of 2024. You can see year-to-date gross revenue was favorable to the budget by $51.1 million, or 3.6%. Outpatient gross revenue came in at $91.6 million. This was unfavorable to the budget by $4.8 million, or 5%, and really due to two things: less observation days, as I've mentioned, and also we had less outpatient surgeries, and we'll see that. Year-to-date revenue was consistent with the budget by $5.1 million or 0.5%. Looking at our inpatient average length of stay, came in for May at 5.21 and was consistent with the budget of 5.22. We're very close in terms of it. Also, we saw the CMI for May increase from the prior month by 0.119 to 1.713, but we had budgeted 1.848, so a little bit unfavorable to the budget, but higher than the previous month. Looking at our discharges trend, May saw 1,045 discharges, which was favorable to the budget of 971 by 7.6%, again, due to lower observation days, and year-to-date discharges were unfavorable to the budget by 125 or 1.1%. Also, we had eight patients that were over 30 days in-house. We are seeing a little bit longer length of stay on some of our patients. Moving on to patient days, they came in at 5,563. They were favorable to the budget of 5,063 by 500 exactly, or 9.9%, and were 824 days or 17.4% favorable to May of 2024. So there were 288 days for trauma patients, which was favorable to the budget, and without trauma, the patient days were also favorable to the budget by 420 days or 8.7%. Looking at our inpatient average daily census, came in at 179.5, which was favorable to the budget of 163.3 by 16.1 or 9.9%, and again, aligned with the higher patient days. Year-to-date, inpatient average daily census was 170.8, which was unfavorable to budget of 173.9 by about 1.8%, but favorable to last year, year-to-date. Right, so looking at our surgical trend, total surgeries in May came in at 541, which was favorable to the budget by 530 by 11 or 2.1%. And were 3% favorable to May of 2024. Year-to-date, cases were relatively consistent with the budget by about 14 cases or negative 0.2%. Again, as mentioned, inpatient surgeries of 277 were favorable to the budget by 24 and 9.5%. And outpatient surgeries of 264 were unfavorable to the budget by 13 or 4.7%. We did do 8 TAVR cases in May. This is the breakdown of the surgical activity. In terms of, you can see we came in 7 cases less for orthopedics. We did see the UCSF trauma team was doing more than budgeted, but was offset by others being more shifting to the outpatient, or ASC, I should say, from that standpoint. You can also see vascular was down by 6, and urology down by 8, and other down by 21. Other encompasses ENT and OBGYN, along with pulmonary, were the 3 areas that were down. But we did have a good cardiac, was up by 21 cases, or 27 cases, and general surgery was up by 14. Moving on to cath lab, you can see May cath lab cases of 191 were unfavorable to the budget by 13 or 6.4%, and were also unfavorable to May of last year by 2.1%. Cath lab inpatient cases of 103 were unfavorable to the budget by 9.6%, and outpatient cases was also unfavorable to the budget by 2.2%. To move on to the next page, you can see in terms of the areas that we were below budget, both in cardiac and interventional radiology were up by, in neuro IR by 2, and vascular we were down by 8 cases, so overall down by 13 cases. Deliveries continue to be busy with deliveries. We came in at 139 cases, which was favorable to the budget by 13 or 10.3%, and were 18.8% favorable to May of last year. Year to date, they were favorable to the budget by 117 or 8.4%. We did have about 50 C-sections of the total cases. Our C-section rate did pop up to about 36% for this, so it was higher than the other months. It's something we continue to look at and work on. Looking at the non-emergency department outpatient visits, they came in at 9,222. They were unfavorable to the budget by 279 or 2.9%. As you can see, the budget numbers, we have been increasing, but they were higher for, even though in May there was one less day compared to April with a holiday. In terms of the areas that were unfavorable to budget, we saw that in lab and x-ray, about 7%, and that was offset by cardiac rehab being above budget by 12.9%. Moving on to our emergency department visits, they came in at 5,399. I know that they're unfavorable to the budget by 5.6%, but May was the third highest month after December and January. So even though it's still busy in terms of our emergency room. We saw less than budgeted types of cases for intermediate level, and then just about also less critical cases or level 6 cases. That overall will see busy emergency room visits. All right, moving on to the gross revenue recap for May. See that surgical services were above budget by 4%, and again, cases were also favorable to the budget by 2%. I will say you might notice in terms of cath lab revenue was 22% or 2.4% above budget, despite being below budget in terms of cases. Some of this was the mix of cases, but also we did have some. It was a timing issue. We did have some at the end of April, some of those cases, the gross revenue was recorded in May from that. So that was also driving it. Otherwise, you can see in terms of the other areas trending with the increase in volume, both on birthing center, room and board. Also, again, with emergency department revenue was favorable to the budget despite having fewer visits than budgeted. And some of that was due to trauma. Trauma was $3.4 million was favorable to the budget. So that also was driving some of that increase in revenue from the emergency department. You can see our preliminary payer mix overall in terms of government payers, pretty consistent with what we had budgeted. In terms of HMO, that you see that in terms of favorable to budget in terms of 4% versus a budget of 1.8%. And then PPO being below budget, coming in at 18.6% versus 21.2%. So in terms of looking more into sort of the HMO cases and what we're seeing there. So I know that's something that we're looking into. Looking at our productive FTEs for May, they were favorable to flex by 40.8 or 2.7% at 1,512.4 FTEs. Year to date was favorable to the budget by 65.1 or 4.2%. Non-productive were consistent with the budget, basically by 0.1 or 0.1% at 178.9 FTEs. Then looking at our total FTEs for May, they were favorable to the flex by 41 or 2.4% at 1,691.3 FTEs. Looking at our total FTEs per adjusted occupied bed, we did come in at 5.73. That was favorable to the budget of 5.89. So we need to do better in terms of that total FTEs per adjusted occupied. Moving on to Radiation Oncology Center, treatments were at 307. They were below budget by 18.8%, But if you can see, May in the past has also been a slower month. May of 2024 was 280, so higher than May of 2024. I will say that we had more complex types of cases. We had more IMRT and SRS and SBRT during this month. So our volume was lower, but we did see more complex cases.
I'm wondering if we can adjust that so that it's more.
Yes, I think in terms of looking at that, it just seems, and I know we had spoken with the director of oncology, and she had said that it's similar for whatever reason. May seems to be a little bit slower. So yes, when we do the budget spread, we can take a look at that. I will say that if you look at the consults, they still remain, steady in terms of 26 consults for new referrals for the month of May. Also, May's conversion rate came in terms of how many were converted from referrals into patients that were being treated. Came in at 30.8% compared to April's at 25.7%. So we'll see more cases going through. Moving on to our preliminary outpatient statistics for Washington Health Medical Group, they came under budget by 1,333 or 7.6%. This was really in two areas. The first was in pediatrics. We are down one physician, and we do have a new provider that started yesterday on June 10th in pediatrics. So hopefully we will be seeing an increase in pediatrics, because I know staffing's been a challenge. The other area in terms of our clinics was Warm Springs, with a new provider that has also been just starting to ramp up over there. So those are some of the two areas really that are driving our being unfavorable to budget. In our specialty care visits, we did have women, they came in favorable to budget. Women's health came in over budget, along with vascular too, specialty care. Looking at the Development Corporation, those outpatient visits of 2,246 was unfavorable to the budget by 36 at 1.6%. In terms of that, just looking, our Washington Outpatient Rehab Center came in at 3.9% over the budget, but that was offset by Washington Outpatient Surgery Center that came in 37 or 6.6% of cases under budget, and then PSC was also unfavorable to the budget by 23.7%. We did have one of our physicians that was out for a couple weeks during that month. So that was really driving that. And then lastly, in terms of looking at our key financial statistics, for May, days cash on hand came in at 133 days. Compared to April, they came in at 127 days compared to April's that came in at 133. We did have a number of factors that contributed to that decrease in days. We did have payroll taxes. There were 3 pay periods in April, and the taxes for that third pay period that ended at the end of that month paid in early May. We also had an IGT that needed to be, that we did for over $1 million. And we also had a number of outstanding checks that we paid in terms of large payments for contractors and others that we had during that month. We did have a good collection month in terms of that helped, and we did receive funds for ASWAC also during that time. So we had some of that offset. And lastly, charity care came in at $306,000. So it's a little bit more than we had seen the previous month. Yeah. All right, that is May. Any questions?
Calendar?
I think the good thing that I was saying was the deliveries have gone up over the budget for the last 6 months, back to back. Everything which has ever happened in the last 20 years that I've been here.
I know, and I was thinking about that when we were talking about the budget, because if you saw, as you know, if you've seen our delivery slides, and I know you've commented quite a bit on it in terms of we've been going down, but now, yes, we have been going up.
Something's happening this year, maybe the moon is on the rise.
Yeah, there's some of that.
Maybe the population is increasing.
Yeah. To get the line back up.
Yeah.
Exactly.
The population is decreasing, remember you?
I know, we saw,
Post-COVID, but that was through like 22.
Union City got to be refilled, I think.
yeah, so, I mean, I think some of it is St. Rose, as you know,
St.
their
Rose,
labor
yeah.
and delivery, there's some of that, I think coming our way, and I know the team's continuing to work and look at, I know some of the groups are bringing in new OBs too, so hopefully as we see, that continues too.
July looks like predicted to be record month for the last at least 2021. I've been looking back, so pulling our seatbelts. We'll see what happens. But yeah, you're right.
Yeah, so
It's a good thing.
we'll see. Yep.
Yep.
I know. All right, moving on to our calendar. We're going to do Employee of the Month to begin with. My pleasure to introduce our Employee of the Month for June, and that's Harvey Fortune. He is a biomedical electronic technician. Harvey Fortune is one of those lucky people who had a skill set that he was able to develop and segue into a career. Though he is a skilled auto mechanic, Harvey decided a degree in electronics would be a better career move. When he joined the staff of Washington Health 7 years ago, Harvey had extensive knowledge and experience in the biomedical engineering field. He started his career at California's Pacific Medical Center in San Francisco. He worked there for 11 years, with the last 4 years as chief engineer. He also worked with Stanford Health in Palo Alto for almost a decade and held many positions there. As a certified biomedical technician, Harvey and his co-workers have 3 main responsibilities: repair medical equipment, perform preventive maintenance, and work on planned projects such as the upcoming Alaris infusion pump replacement. Harvey's manager and co-workers praise his positive attitude and his exceptional innovative abilities. He is a critical part of the team. As part of a military family, Harvey moved several times as a youth. He has lived in multiple states from New York to Hawaii and also in Germany and the Philippines. Harvey believes the greatest gift this lifestyle provided was learning to work with people from different backgrounds with different experiences. When he is not at the hospital, Harvey's mechanical skills are often put to use in helping neighbors and family members with various projects. So I think Harvey and the rest of the biomedical team are very important parts of our care team overall, and we're very excited to honor Harvey as Employee of the Month. All right, I'm going to move on to our community outreach events for May. Let's go through those. All right, so a snapshot with May. As you can see, we were out in the community. We had the Special Olympics track and field event that we had over 550 athletes there from New Haven, Newark, and Fremont. And our sports medicine and athletic trainers were there. We also hosted Bike to Wherever Day, which we had about 50 riders visited our Energizer station and appreciated everybody who stopped by. We hosted the Celebration of Life here in Anderson Auditorium. We had 90 attendees. You can also see in terms of, we hosted a booth at the Newark State of the City address. There were over 150 attendees, and also Dr. Kalsa, one of our neurologists, did a Facebook and YouTube education and had over 900 views there. We had trauma outreach, Stop the Bleed at the Ruggieri Senior Center. Also, you can, I do want to just also thank Angus and Kayla for their work on the Behavioral Health Symposium. As you saw, and as we know, behavioral health is an important need in this community. We had it was really a 2-day event, one really focusing on professionals. We had over 50 attendees. We had Dr. Karen Tribble that was our keynote speaker. She did an excellent job talking about the county and behavioral health resources and how important it is that we really all work together and not in our silos. On then the Saturday, June 7th, we held a behavioral health fair for the community. We had over 100 attendees and really had presentations from other community related organizations. And then lastly, tonight you can see Dr. Wong endocrinology is doing a Facebook and YouTube. Okay. These are just some pictures. And this is just a list of our upcoming outreach events, and we have some great events that we'll be at or hosting. You can see a very important one on robotics that Dr. Kranthi Achanta is going to be giving on June 25th on Facebook and YouTube. Also, just in terms of, we will be present at all of the summer concert series that will be kicking off on June 26th. So those are important, and participating in other events with organizations in June. Just lastly, and also you can see we will be at the livestock auction.
All right.
We will be again at the Alameda County Fair Junior Livestock Auction, and then also Dr. Sabaya is going to be talking about vascular disease. So. Great.
Livestock auction seems to come around very.
I know, I was thinking the same thing. It's on. We were just there. So I know Angus and I will be very excited to be talking about it in July. So, very much so. And I know it's in the budget, correct?
Did you put that in the budget?
We don't mind going over budget on that.
You're gonna front load that budget in for July. That's how that budget works.
I can neither confirm nor deny.
All right, almost there. Then lastly, just in terms of from the Health Foundation, I do just want to say, as you know, we totaled more in gross proceeds from the golf and bocce tournament, over $124,000, and we netted over $72,000. So that was a good event for everyone that participated. And just a reminder about Top Hat on October 12th. And also we have the scholarships that we continue to receive applications for. All right, that is the calendar of events.
Great. Thank you, Kimberly. So we have one remaining action item, and that's item C. Dr. Ethan, go ahead and introduce them, and then we'll have Kimberly comment.
Mr. President, I move for the adoption of resolution number 1272, and that the Board of Directors authorize the Chief Executive Officer to proceed with entering into a contract with the Freight Checkers, Clerical Employees, and Helpers Union, Local 856, International Brotherhood of Teamsters.
Thank you. Do we have a second?
I'll second that.
Thank you.
So as I know there is a memo from me, or from John Dubiana to me regarding Local 856, they represent, the union represents about 130 employees, consisting of accounts payable associates, health information staff, reg clerks, patient accounting representatives, cashiers, scheduling, lab secretaries, and many other areas too. We reached a tentative agreement for a new 3-year contract, which was ratified by Local 856 on June 4th. And as mentioned, the agreement is 3 years. It goes from September 1st, 2024 through August 31st, 2027. There are wage increases each year across the board of 4.75%, and then some other differentials in terms of shift differentials and per diem aligned with the market. So our recommendation is to move forward with approving this.
Thank you. Any questions? If not, Cheryl?
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen?
Aye.
And Director Wallace?
Thank you. The resolution is adopted. Kimberly, any announcements?
No announcement.
Okay. Any questions or concerns from other board members? If not, this meeting is adjourned. Thank you.
Right.